So the next session, Symposium, will be based on the title Equity in Healthcare, and it will be chaired by Professor Diniti Fernando, Department of Physiology, Faculty of Medicine, Colombo, and Dr. Santosha Fernando, Consultant Community Physician, Department of Medical Humanities, Faculty of Medicine, Colombo. Thank you.
Hi everyone. It's my pleasure to chair this session with Dr. Santosha Fernando, my co-chairperson. And the title is Equity in Healthcare, and we have 3 speakers. This is the last symposium for the day. And this I would consider a very important symposium because it directly resonates with the theme of this conference, diversity, inclusivity, and equity. And I trust we all will find new insights through this symposium, and I would hand over the mic to Santosha to introduce the first speaker.
Ladies and gentlemen, the first speaker is very special to me because she's from my second home, Pakistan. She's Dr. Somia Iqtadar, Associate Professor of Medicine, North Medical Unit, King Edward Medical University, Mayo Hospital, Lahore, Pakistan. Dr. Somia Iqtadar is the Associate Professor at King Edward Medical College, Mayo Clinic, Lahore, and also serves as an adjunct faculty member at the University of Health Sciences and the Institute of Public Health, Lahore. She supervises MD, MRCP, MPhil Public Health, and FRCPS Medicine students, and is an advisor to the WHO EMRO on arboviral diseases. Recognized for her contributions to health, she has received numerous accolades, including the Health Icon Award 2024, the Award of Excellence in Recognition of her contribution to diabetes care in 2022, the Charles Wallace Fellowship Award for 2022-2023, and the Governor's Award 2021. Dr. Iqtadar has authored over 50 research papers in national and international journals and has been named among the top 100 women in global health Pakistan chapter. She is a fellow of the Royal College of Physicians, London, and Pakistan Society of Internal Medicine, and the College of Physicians and College of Surgeons in Pakistan. And today I invite her over to the podium to speak on women in healthcare leadership and Asian perspective. Ladies and gentlemen, Dr. Somia Iqtadar.
Women in healthcare are just not caretakers. They are decision makers. Because when you include women in healthcare leadership, they bring in a new perspective, empathy, and resilience. Good afternoon, ladies and gentlemen. I'm very honored to be here at the 57th annual meeting of Ceylon College of Physicians. And today I will be talking to you about the role of women in health leadership from an Asian perspective. And we will be examining the current trends, challenges, and the remarkable progress that is being done in this field. Okay, so we begin by examining the industries where women have a strong presence. In healthcare and social assistance, women are about for 53%, and this is followed by the educational services at 45%, and administrative and waste services where they constitute about 37%. When we look at the different shares of selected occupation, you find that women are mostly in the pre-kindergarten, dental assistants, registered nurses, but there are few in the medical career like physicians and surgeons and lawyers. But if you talk about the employment in the health and education sector, you would see that there is female predominance in the high-income countries, but as we go down to the upper middle and low-income countries, the percentage of females contributing to the health and education employment becomes considerably less. And similar is the role of gender in the leadership positions. So in the leadership positions, if you talk about the first level, higher level, then men constitute about 70% of the leadership positions. But in the mid-career levels, it is about 73% and women are 27%. But when we go up to the senior levels, that is CEOs, then there are only 21% women against 79% of men. These are figures from the World Economic Forum, which shows that women are hired into leadership positions. And this is a yearly analysis which shows that though we have made progress by including more women into the leadership positions starting from 2016, where they were only 33%, jumping on to 37.1 and 37.5% in year 2021 and 2022. But now again, in 2023 and 2024, we are down to 36.4%. So we need a lot of progress still, to come up with more women in the leadership positions. So there are a scale of the challenges. We all know that women, they constitute about 70% of the global health workforce. But when we come up to the leadership positions and senior leadership roles, then they are only 25%. And this is also in the high-income countries only. When we come down to the low-middle-income countries, then it is only 5%. And less than 15% of the senior academic roles, they are held by women. So there is a need for change. So the global health is weakened by loss of female talent, ideas, and knowledge that they share. And women leaders, they often have seen that they expand the health agenda, they strengthen the health for all. So the gender disparity, if they're dropped out, the females from the senior leadership positions, it impacts negatively on the health outcomes of women and child globally, but as on health overall. So gendered leadership gap in health is a barrier to reaching the sustainable development goals, particularly in the low middle income countries and the universal health coverage. This is the geography of the global leadership. If you see in this, in the high income countries, you would see that about 83% of the global health leaders are females, but 50% of the global health leaders are just from two countries, which is UK and US. And if you compare it with the low and the middle income countries, you would see that only 5% of global health leaders are women from low and middle income countries, which is actually even less than the leaders from the high income countries who have degrees from Harvard. The same, all degrees for low middle income countries combined is even less than those from the Harvard graduates only. So this generations to parity in region, this is again a slide from the World Economic Forum. And the projections based on the Global Gender Gap report, this shows that the Latin America and the Caribbean will achieve the gender parity in 2 generations, the Europe in 3, and regions like Southeast Asia and Pacific, they would need 7 generations to overcome this gap. And that is how the sad situation is in the Asia, which we are focusing today. This is the Global Gender Gap Index. Out of the 146 countries, unfortunately, the country that I am representing, Pakistan, is on the 145th position. If we talk about other countries from Asia, particularly Southeast Asia, Maldives is on 132 number, India is 129th, Bhutan is 124th, Sri Lanka is 122nd, and the highest among Southeast Asia is Bangladesh at the moment with 99th position in the Global Gender Gap Index. So Pakistan faces the gender gap crisis, ranked the lowest, 145th out of 146 countries on the Global Gender Gap Index in the latest 2024 reports. And if we talk about the percentage of health ministries which are headed by women, this is the report from the Women in Global Health, you would see that while in the European regions, 36% of the ministries are held by women, in the Asian regions, it is only 18% of the ministries which are headed by women. And the member state delegations to the World Health Assembly are often discussed how many of them are headed by women over time. And in 2017, where World Health Assembly, 70th World Health Assembly was conducted, there were 31% of the member state delegations which were headed by women, but we've come down to 30% by year 2024. So instead of improving and progressing to a better representation of females, we've come down actually to 30%, which needs a lot of deliberation by all the senior professionals. So talking about the women representation in healthcare, as I already mentioned, Women make up about 70 to 80% of the healthcare workforce if I talk about the Asian figures. The women, they generally dominate the nursing and midwifery roles, but they are underrepresented in the top executive position. The leadership roles like CEOs and directors, you see less than 20% of female representation across most of the Asian countries. If we talk about India, women in leadership roles are only 10 to 20%. If we talk about China, there are senior management roles of 30%, but the executive roles are again less than 10%. We talk about Japan, these are all developed countries. The top leadership roles are only 5 to 10% held by women. Talking about Thailand, Indonesia, and Philippines, women hold 20 to 30% of senior roles in the healthcare, but the CEO level positions are again down to less than 10%. So if we have to make this balance between men and women in the leadership positions, I think it is very, very important that we need to emphasize the need for the systemic reforms to achieve a gender equity across the various sectors. So these are some of the women in the leadership roles globally. Women hold about 12% of Fortune 500 healthcare CEO roles and 25% of the global health minister positions, yet they constitute 70% of the health workforce and so much underrepresented. And this data underscores the disconnect between women's workforce participation and their representation in the leadership roles. Talking about Southeast Asia, the representation in the health ministries, India has only 15% of senior roles assigned to females. Pakistan has 10 to 15% of leadership positions assigned to females, and Sri Lanka is doing a little better with 20 to 25% of leadership positions. So let's find out what are the barriers to the women advancement. This is a study which was published in Lancet in 2019, and women face significant challenges in advancing their careers in healthcare with work-life balance, gender discrimination, and sexual harassment, which are acting as the key barriers for their progression. And addressing these issues is essential to supporting women's progression into the leadership roles. So this is a study which was conducted by Dr. Shabnam Sarfraz from the Women in Global Health. She's the Pakistan lead, and she looks after the gender portfolio. And this study, it shows that the aim of the study was to identify the successful strategies, barriers, and the necessary steps to enhance the women's representation in leadership positions. And the findings, they informed that the mentorship programs and policies to promote gender equity in healthcare were the most needed things if we want to address these issues. So of the 55 women who did confront this gender-specific challenge, 67.3% stated that presence of gender-insensitive career advancement practices is the main challenge. And they said that they face these barriers in the career progression, and this is one of the major issues that needs to be addressed. So apart from this, the barriers to the career advancement, almost 1/3 of the respondents cited that completing responsibilities of families and not having a daycare facility is a hurdle to the advancement of their career. And 45% rendered a lack of mentors as a barrier to their career advancement. So it is very important to have a mentor in your life for your better performance and your career advancement. And when they were asked about the least supportive relations, they cited that 40% of them, they didn't have a good supervisor, and 35% of them, they related it to their families, particularly parents-in-law, who were the least supportive in anchoring their careers. Talking about the enabling factors in the career progression, the training opportunities and the mentorship opportunities, they were found to be the most helpful in enabling factor in the career progression for women transformation. So why women should be leaders? I think the characteristics of a woman which distinguishes them from a male, like transformational leadership style, they're more task-focused, they prefer to work in collegial atmosphere, they promote cooperation, collaboration, teamwork, their communication, and their self-branding. These are the important things or characteristics of a woman leader. And women leaders are definitely doing a better job than men during the crisis. This was a survey which was done by a 360-degree feedback data between March and June. And it was after the 2008 financial crisis that showed that institutions and countries who have higher representation of women in leadership, particularly in the financial sector, suffered less from the global economic crisis. And this has increased the calls for more outstanding gender balance in leadership. And Europe has seen an estimated increase from 15% in 2007 to 34% in 2016 in women's representation on boards of directors in central banks. So pre-pandemic and post-pandemic, we've seen that the leadership effectiveness ratings were better for females. So this was another survey which was done in 2021 by McKinsey and Company, and they showed that out of the 423 companies across the US and Canada, women were better than men at providing emotional support to their employees, considering the well-being of their employees, helping the employees navigate work-life challenges, intervening to prevent or deal with employee burnouts, and leading and supporting diversity, equity, and inclusion efforts. And there was a marked difference when you compare the figures between the men and women. So the women performed overall better in multiple aspects of leadership, and these are the qualities which are very critical to the healthcare industry. So I believe that no woman should ever grow old before knowing her true potential. And for this very reason, we took up this initiative with Royal College of Physicians, London, and I'm very grateful to Dr. Mumtaz Patel, acting head of the RCP London, for taking this initiative of bringing the Global Women Leaders Program to Pakistan in collaboration with Pakistan Society of Internal Medicine. I think this is one of the most exciting and most successful academic collaboration that we've done in the recent years. It was to address the challenges of how to motivate and inspire women to aspire towards leadership roles as a key strategic goal. And the thematic analysis emphasized three key themes related to the advancement of women in medicine. One was the practical difficulties, including the childcare needs, the lack of timely career advance, and part-time working. The second was the social barriers, which include the maternal identity and the cultural pressures with respect to the work and family balance, how we need to address that. And the third, importance of building resilience through role modeling, mentorship programs, and supporting one another, peer support program. So to address challenges and to motivate and inspire women to become good leaders, I think these were the three areas that were mainly in focus. And this has been published in the newsletter of the RCP as well. We started with the launch ceremony on the International Women's Day, followed by two sets of events, one for the champions and one for the mentees. The 3 days workshop on the women leadership in healthcare was organized in collaboration with Royal College of Physicians, London, by Pakistan Society of Internal Medicine as a part of Global Women Leaders Program, and selected women physicians from all over Pakistan joined the session and greatly appreciated the activity. They were then joined together in a mentor-mentee relationship. The Women in Global Health Pakistan Advisory Board, that was also formed as a constituent feature of this Global Women Leaders Program, headed by Dr. Shabnam Sarfraz, who is a women leader herself, and joined by the senior physicians of the country. This Women in Global Health Pakistan Power Delegation then represented in the Gender Equality Forum in Paris in 2021 as well, where senior physicians and mid-career physicians, they represented Pakistan leadership, women role in leadership in healthcare. When you start a good initiative, people start joining in. And this is what happened with the Global Women Leaders Program and the initiative of Pakistan Society of Internal Medicine, that another organization, which is Women in Leadership League in Pakistan, that was formed. That was by sponsorship of a pharmaceutical initiative, but it was a non-marketing and non-promotional kind of activity that they invested into. And they identified the female icons of healthcare industry and discussed the strategies to overcome and the challenges that are faced by the Pakistani healthcare physicians, the female healthcare physicians in Pakistan. And this collaborative effort has been going very well. So from this forum, I had the honor to attend another leadership platform which was held in Paris during the EuroPCR meeting, which is Women as One. And the women physicians from all across the globe, they seek collaborations and opportunities for academic and research support from the health industry. And I think it is a very collaborative and very successful model that we all can follow. So in the journey of women leadership, actually the Global Women Leader Program by RCP London emerged as a guiding force, and their vision extended like an umbrella, steering of all of us, and the great efforts were then joined by the pivotal support of Pakistan Society of Internal Medicine, guided by the strength of women in global health and the determination of the Women in Leadership League in Medicine and unity of Women as One. So the women, they rose as leaders, holding this umbrella, making it stronger, empowering women together for a bigger and a brighter future for women in leadership roles in healthcare. I would like to end my talk by saying Rupa Dutt is the Executive Director of Women in Global Health, and she emphasizes the need for systemic reforms to address gender inequalities, and the focus should shift from individual responsibility to changing the systems that perpetuates the exclusion and discrimination. So she says that when you find yourself excluded, don't ask, what's wrong with me? Instead, ask, what's wrong with the system and how does it need to change? The journey towards gender equity in healthcare leadership is ongoing. Continued support, advocacy, and systemic changes are essential to ensuring women can thrive and lead in the healthcare system. My salute to all the women leaders in the healthcare. May the force be with you. Thank you very much.
Thank you, Dr. Iqtadar. Please come and sit here. So it's my pleasure to introduce the next speaker of the symposium, Dr. Emma Mitchell. Dr. Emma Mitchell is the Associate Global Director for International Medical Graduates at the Royal College of Physicians, London. She is also a geriatrician with a special interest in Parkinson's disease, working at Southmead Hospital, Bristol, UK. Most recently, Dr. Mitchell has worked alongside local and national stakeholders on the delivery, implementation, and evaluation of the Medical Support Worker Program to support refugee doctors into NHS practice. And she's going to talk to us about mechanisms for supporting the integration of refugee doctors. Over to you, Dr. Emma Mitchell.
Good afternoon, ladies and gentlemen. I'm delighted and honoured to be here to speak with you today. And thank you very much to all of the organisers of this conference for your generous invitation and also for the opportunity to take part in the leadership course that happened yesterday at the PGIM. Thanks also for the introduction. So as mentioned, I work with the RCP in London as the Associate Global Director for International Medical Graduates, and part of my role is overseeing the Medical Training Initiative programme. And I also work as a geriatrician in Bristol, which is in the southwest of the UK. I'd like to share with you my thoughts around mechanisms for supporting the integration of refugee doctors in the UK. And this is a subject matter that's become of increasing interest to myself personally as a clinician, but also features as part of conversations that take part as part of my role with the RCP. Here is an overview of what I'd like to discuss with you today. So I'll start with an introduction, a definition, and some statistics, and then share with you a personal journey of a doctor who found themselves displaced and living in the UK. I'd then like to offer some considerations for things that you might want to think about when integrating refugee doctors into a new healthcare system, some of the challenges faced by refugee doctors, and the contributions that many can have in healthcare systems disparate to their countries of heritage. I'd then like to share some UK examples of support systems that are in place at a regional and national level before closing with some conclusions. So by means of an introduction, let's start with a definition. A refugee is somebody who is unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion. With the number of geopolitical disasters and crises that we see, these contribute to the statistics that are recorded. So globally, in 2023, there are estimated to be 43.4 million refugees, and nearly 3/4 of whom are residing in low and middle income countries. When focusing on UK statistics, in 2022, it was recorded that there were just over 230,000 refugees in the UK, and over the period of around 12 months, 75,658 applications for asylum status. Data from UK-based refugee organisations estimate there to be at least 2,000 healthcare professionals, more than 1,000 of whom are doctors in the UK, trying to find a way into NHS practice. Now to share a personal story. This is from a doctor I had the pleasure of meeting, and also together we contributed to this article that was published in the British Medical Journal. We were afraid to be recognised as doctors. C was working as a senior house officer at a cancer centre in Myanmar when the coup happened. But once the military took over the country, they volunteered at a charity-run clinic. C told the BMJ that health workers were being arrested, tortured, beaten, and even shot to death for taking part in the protests, for trying to deliver healthcare, or simply for teaching medical students. Many of us had to go into hiding to avoid the military's radar, said C. We were afraid to be recognised as doctors, and we had to provide medical care in secret. So now I'd like to take the opportunity to offer some considerations when thinking about integrating refugee doctors into a healthcare system, and this is through a UK-based lens. So to consider the individual, for doctors who find themselves displaced in a country unfamiliar to their own, unable to work, unfortunately, there is a risk of brain waste and a high risk of loss of professional identity. Many refugee doctors in the UK have to find themselves taking up interim jobs, for example, working as taxi drivers. Consider the NHS. So in the NHS, there are estimated to be high numbers of doctor vacancies, and there are many doctors already in the UK who are ready and eligible to work. Consider our local communities. In the NHS, we serve very diverse populations, and by having a diverse workforce, we can better serve those populations. Consider UK taxpayers. It's always worth strengthening the moral argument thinking about economics. And the asylum processing system in the UK costs UK taxpayers in excess of £1.5 billion per year. And lastly, as our role as global health citizens, which we all are, and I'd like to present the question of what happens to doctors who are desperately wanting to return home at the earliest opportunity that it's safe to do so, if they haven't been enabled to be able to continue to progress their careers in the country that they find themselves displaced to. So it goes without saying that refugee doctors have to go through many challenges to be able to find themselves established in a different country. In the UK, there are requirements for GMC registration, which requires specific documentation, the availability of which may not be possible, for example, due to collapse of administrative systems. There are exams that are required in order to be able to get GMC registration. This takes time to prepare for. It's also very costly. Other than GMC registration, being able to get a valid visa and right to work is also a lengthy process, with around 2/3 of initial asylum applications being refused and having to go to appeal. Once GMC registration has been obtained, there's also then the journey of being able to try and find a job in the UK. So being able to prepare a strong application and prepare for an interview in a country that you're unfamiliar with, where there are different systems, different working cultures. A refugee doctor may not have many contacts or people that they are able to turn to for advice, for mentorship. They may have experienced significant traumas, and the availability and access to proactive psychological support might not be available. And then when starting work, there are all the challenges of integrating oneself into a completely new system, be that new technology, be that different working cultures, be that even just a sense of belonging and being able to hold a conversation over lunch with new colleagues. There may also be challenges when trying to find suitable housing, childcare arrangements, and accessing healthcare. It is clear to see that refugee doctors can provide significant positive contributions to healthcare systems, specifically referencing the NHS. So not only could they help to support workforce shortages and provide an opportunity for national cost saving, they also present diverse breadth of clinical skills and experience. And I'd like to, at this point, reference the Experts in Our Midst work, which has been coordinated by the Tropical Health and Education Trust. Their aim was to recognise the contributions of healthcare diaspora staff in the UK and to identify approaches to enable, engage and empower diaspora staff within the NHS and with countries of their heritage, recognising that many continue to be involved in that work. And key to this piece is the concept of cultural competence. So the diversity of perspectives which help to enrich medical practice and improve patient care. And this spans many themes, for example, communication. So diaspora staff may understand how words and behaviours may be interpreted differently, and that can help to empower people and patients. Skills and flexibility, adaptability, being able to work effectively within the resources that you have. And also a profound appreciation and respect for other cultures, which may help to understand the healthcare behaviours of ethnic minority groups when accessing NHS care. So now I'd like to turn to have a little look at what support systems are in place currently within the UK infrastructure. So first, the General Medical Council, which is the professional registration organisation that all doctors have to hold in order to be able to practice in the UK. They provide guidance on documentation required for registration, as well as financial support for things like registration fees and administrative fees. The British Medical Association, which is the largest trade union representing doctors in the UK, have something called the Refugee Doctors Initiative, which has access to educational materials as well as access to a counselling service. And both signpost regional and local organisations that doctors may access as a refugee. At the RCP, there are a few things that are underway at present. So one is an aspiration to have an area on our website, on our global website, in order to be able to share stories, share examples of best practice, and again, to signpost key organisations and resources. We're exploring free, or at the very least discounted, RCP membership for refugee doctors, and at present taking part in several high-level stakeholder meetings to advocate for the development and implementation of structured pathways for refugee doctors to begin working in the NHS. I'd now like to share with you a bridging programme. So this is an example of a bridging programme for refugee doctors to be able to begin working in a safe and supported way in the NHS system. And this programme is something that I had the pleasure of being part of, both nationally and then also locally within my own organisation in Bristol. So the Medical Support Worker programme was initiated in part in response to COVID. as a mechanism to deliver a rapid pipeline of staff to the NHS, whilst also providing this safe and supportive environment for doctors who are beginning their careers in the NHS system, and perhaps whilst also gaining GMC registration. It was funded by NHS England for around a 2-year period, and during that time frame, over 1,000 medical support workers were employed across the UK. So I'd like to share some of the local experience of being part of this programme. In Bristol, we had the pleasure of working with nearly 60 medical support workers employed through the 2 cohorts of the medical support worker programme. Our second cohort were only in post for a shorter time period than the first cohort, which is perhaps reflected by the numbers of doctors that managed to secure GMC registration during that time period. But what has been a fantastic part of this programme is that many of the doctors have then continued on into clinical fellow roles within the organisation, being able to make a start for themselves, be settled in the local community, progress their careers and really strengthen their CVs to go on to do whatever it is they hope in terms of further career progression and training. We collected various data to illustrate the benefits to the individuals and the clinical teams with regards to engagement with the medical support worker programme. So benefits to individuals were predominantly reported to be around building confidence, for example, in advance of exams such as the PLAB, developing CVs, improving English language skills, and gaining hands-on experience of NHS working culture, which strengthened subsequent applications to get GMC registered jobs. Benefits to the teams, so importantly, the junior doctors who were working alongside medical support workers shared many positive stories about how there was some task shifting, so the medical support workers were able to help support with various clinical and non-clinical tasks. It also provided an educational opportunity for the junior doctors to be able to teach medical support workers who are learning how to work in the NHS system and increase staff capacity, which then in turn allowed the junior doctors to be more reliably able to attend their own teaching programmes and be able to take leave. The benefits that supervisors recognise were a huge positive impact on teams, the fact that medical support workers complemented existing teams and also helped to support staffing shortages, providing an extra buffer and extra capacity. I think key to the success of the implementation of this programme was recognition that there needed to be a package that came around the support offered to this group of doctors. And so we provided an enhanced induction, which was supplemented by material by international graduates working within our organisation. We provided support to meet expectations and provide context to the supervisors supervising medical support workers. All MSWs had access to ePortfolio, which is an electronic mechanism for recording professional development and training that is required of doctors in the NHS. And then we provided an array of training and teaching covering areas that might be unfamiliar, for example, training in quality improvement, with proactive access to clinical psychology, and also training to help pass exams, prepare for interviews, as well, importantly, as social gatherings and an opportunity to meet outside of work, share some food, share stories. 2 regional support programmes I'd like to mention are REACH, which takes place in the northwest of the UK, and Building Bridges, which is based in London in affiliation with the Refugee Council. Both provide quite similar infrastructure. For example, Building Bridges provides peer-to-peer network and professional development group sessions, fostering that sense of belonging and network. Importantly, this topic requires advocacy and awareness building. At a national level, within our national health strategy, the NHS Long-Term Workforce Plan recognises the number of refugee doctors situated in the UK and the important contributions that they could have and should be integrated as part of our blended workforce plan. There are conversations at the moment driving the implementation of better national coordination of regional refugee networks, programs of work and sharing of best practice to scale these or to adapt these for local implementation. Raising awareness at local level, at communities, with local MPs, with local mayors, as well as with national parliamentarians, that refugee doctors are assets. And we're also exploring re-implementation of the medical support worker programme. So in conclusion, the scale of global displacement and migration of healthcare professionals is large and will continue to be influenced by geopolitical crises. The processes and the needs of refugee doctors are complex and require the availability and responsiveness of well-designed systems. Considering country-specific responsibilities and knowledge of the health landscape nationally will help to inform priorities and actions. And the contributions of refugee doctors are sizable and positively benefit health systems and patients. I hope that I've shown that various support systems exist in the UK and could be adapted for local context. Thank you very much for your time. Cheers.
Thank you, Dr. Emma Michelle, for that presentation. We will take questions at the end of all three presentations. Now I have the pleasant task of introducing our very own Professor Panduka Karunanayake. He's the Professor in Medicine and Consultant Physician, Faculty of Medicine, University of Colombo. Professor Karunanayake is a professor in the Department of Clinical Medicine in the University of Colombo. He has been a specialist in general internal medicine for the professional unit in professorial unit in medicine at the National Hospital of Sri Lanka, Colombo, for over 20 years, where a significant proportion of his patients have been derived from Colombo's urban poor. He is qualified in sociology and has taught medical sociology in the Faculty of Arts in University of Colombo. In the Faculty of Medicine, he has been the chairperson of the Humanities Society and Professionalism stream for the MBBS program. He was the president of the Ceylon College of Physicians in 2018. And I now invite Professor Karunanayake to make his presentation on health disparities of the urban poor.
Thank you very much, Santosh, and good afternoon to all of you, ladies and gentlemen. First of all, my thanks to the college for giving me the honor of making this presentation. So basically, I need to start off by expressing my debt to some persons. In our department, in the medical faculty, we have a program called the home visit program, where medical students in their final year select patients and go and see these patients at home to make the connections between their illnesses and their social environment. And that was conceptualized by Professor Isra Sharif, whose photo is up there, and who was here last evening for the inauguration, and then developed by Professor Saroj Jayasinghe, who then handed that over to me to continue. So I'm very grateful to the three of them for doing that. And also I'm very grateful to the medical students themselves who are doing the hard work. Some of them are here today, I'm very happy to say, especially to some of the group leaders whose names are appearing there. Now, I've been working in the National Hospital of Sri Lanka, Colombo, for the last 22 years as a specialist in general internal medicine. That basically gives the background from which these ideas are arising, because the NHSL Colombo is a hospital based in an urban area. We do get transfers in from various parts of the country, all parts of the country, but still I think the majority of the patients that we get in our wards are actually from the urban area of Colombo itself. And if you take the urban area of Colombo itself, the more well-to-do people would probably go for private sector care, and the patients who come to our sort of wards are in fact the poor people living in this urban area. Let me start off by talking a bit about the city of Colombo. It's the Colombo municipality area has a population of about 750,000 people and a density of 20,000 persons per square kilometer. In addition to this, we also get visitors every day from outside Colombo, about 1 million visitors every day, and about 250,000 vehicles per day. Now, who are the urban poor? Basically, the term that's used nowadays in sociological circles is called underserved settlements, or USS, people who are living in underserved settlements. That comprises about 40% of the total population of Colombo. And there's no clear definition of what an underserved settlement is, because there are various differences in the settlements themselves from one place to the other. But the basic features that characterize those settlements include things like poor housing quality, overcrowded neighborhoods, unsanitary conditions, insecure environment, lack of good quality infrastructure, lack of access to basic facilities, and so on. The Colombo's urban poor has a very slow annual growth rate of about 1%, which is actually less than the usual rate for a third world city. In fact, it's actually even less than the annual growth rate for urbanization in Sri Lanka. And 80% or more than 80% of the urban poor living in Colombo have been living there for more than 30 years. So if you ask them where is their Gama or their home village, they would say that it's Colombo. So they are long stay visitors mostly. I mean, there is a certain amount of people who are migrating and sort of migrating in and out, but most are permanent residents. There has been some difficulty with terminology because most terms that are used to describe underserved settlements after some time they become derogatory words like slums and shanties and muduku and so on. Nowadays, the word that we normally use is called watta. So how poor are they? The interesting thing is conventional statistics actually suggest that they are not poor. For example, their average income and expenditure are higher than the nation's other two poor sectors, which are the rural sector and the estate sector. More than 50% of them live on a land that they own. More than 75% of houses have multiple floors. As they have a newer generation of children, they build a floor on that, and sometimes they have 2 stories. 80% have individual toilets. 98% have electricity. 90% have municipal garbage collection services. So you can see that there is some physical facilities available to them, and in fact, the interesting thing is a good proportion of them could not even qualify for the Aspasuma because of these physical facilities that they already enjoy. So in what ways are they actually poor? They are poor when you look at it more closely. For example, they have more malnutrition than the other 2 poor categories which I mentioned earlier, and they also have the lowest national dietary energy intake. There's a higher percentage of women employed in unskilled manual work, and that's a good indication of how poor the family is. When the family gets richer, the women tend to stay at home. The population density of the underserved settlements is 4 times the Colombo average, and the average size of a dwelling is 1.5 perches. The infrastructure available to them, although it is available, such as water and sewage and garbage disposal, they are outdated, overburdened, and poorly maintained. 69% of them do not have an access to a community center, which is very helpful for support in times of need. And 84% do not have access to either a savings program or a credit program. So there is a certain interesting thing there where they are socioeconomically all right, but they are not all right. So this is called the socioeconomic distance. They are close to facilities, but they can't reach them. So I'm going to share, to intersperse my talk with some case histories as well, which will probably explain their poverty better. Our first case is a 30-year-old man from Dematakoda, previously healthy manual laborer, who came with basically what looked like illness like acute hepatitis developing over about 1 week's duration. The social history was interesting because he was an IV drug user. He used heroin, and he also shares needles and paraphernalia with his other co-workers. So we tested him for hepatitis viruses and found that he was HBs antigen positive. And then we referred him to a gastroenterology clinic for antivirals and also for follow-up. Regarding his social environment, first of all, he lives in Dematakoda, which is an area that's infamous for drug trafficking and availability. There was peer pressure. He took up drugs and also continues drugs because of he wanted to fit in. He had a dysfunctional family. He lives with his 83-year-old grandmother. His father died of a road traffic accident, and mother has been working in Qatar to make some money for the family for the last 2 years. And he himself is a school dropout at grade 8, and he can only do manual work as a job. So, as customary, we would make a management plan for this patient and discharge the patient to follow the plan up. So it would be interesting to see what will happen to this management plan when we discharge the patient. Now, he's a manual laborer in the informal sector, so he is dependent on his social circles to find work. Social circles applies peer pressure to him to continue his IV drug use. The clinic days and the times are fixed, non-negotiable, and time-consuming. He lacks savings, so taking time off to work is impractical. He needs to attend several NHSL clinics on different days, the gastroenterology clinic, the substance abuse clinic, and the follow-up blood tests also require him to come back to the laboratory on several days. For example, one day you have to come for the hematology test, another day for the biochemistry test. The state sector rehabilitation centers are few and far between and far away. For example, Unawatuna. Income is barely enough to meet his needs, including the IVDU need, so there are no opportunities for savings. The work availability is irregular and haphazard, and if he gets an offer to do some work today, he can't negotiate with the employer to say, can I go to the clinic today? And on top of all this, we know that chronic hepatitis B is essentially an asymptomatic illness until it has advanced liver disease. So he will think, I'll postpone the treatment for another 1 month and keep on working. So you can see that disaster is written into the story already. Now, I went into the sociological theories of urban poverty. The theorization of this has started in the 1950s with a sociologist called Lewis. He came out with the concept called the culture of poverty thesis. So basically, he pointed out that poverty here is not merely inadequate income, but a way of life handed down from generation to generation through well-defined social networks. So they reject dominant values of the larger society, and they have their own values. They have weak family structures, and they also have some personality features which you can see in our patients, such as a sense of insecurity, a sense of dependence, resignation, fatalism, and lack of concerns for the future. So you can understand why a patient like ours that I described to you just now would think that injecting IV drugs, heroin, is a rational thing to do rather than to not to do that because of these personality features. It helps explain why the culture remains even if the physical environment is improved by doing something like giving housing schemes. So what happens when you build a house for them is that the housing scheme deteriorates into a slum with the passage of time. In the 1970s, there were some more theories came up. Adams and others came up with a theory called the theory of marginality. Basically, they pointed out that there are structures in the larger society that perpetuate the poverty. For example, there's geographical marginalization because these people live in separate areas. There's political marginalization. There's lack of political power, weak connections with the center, and poor representation. And there's also economic marginalization because of lack of educational opportunities and poor representation in the industrial workforce. They are only working as employees in the informal sector. They can't get employment in the formal industrial sector. So in effect, what this means is that the way of life that we were thinking about in the earlier theory is actually an adaptation to the marginalization. That's why they occupy land that is not suitable for any other purpose, or participate in the garbage recycling process, or it gets employed only in the informal sector, or there are reactions against marginalization, such as high rates of crime, or violence and unrest, and even riots. But as it turned out in further research, they are actually a very creative, dynamic, and upwardly mobile group. They are not a static group that is stuck in one place. Now, that was beautifully shown in what's known as the voluntary housing action. Basically, what that happens is when a new migrant comes into a particular area as an urban poor migrant, at the beginning, the house is made up of very temporary material, such as cardboard or tin, in a place which is very close to the place where they can go to work. But as they become more established and they become more stable, they gradually go on to other materials, such as wood planks, and then make better houses than the one that they used to have. Eventually, a few years later, you will find that they actually build a house made of brick and mortar and with a tile or with an asbestos roof. So you can see when you follow them up over a period of years, things don't change the same. They are very creative, they are very dynamic, and they gradually go up the social mobility ladder as well with regard to housing, access to work, safety, comfort, security of tenure, status in every way. Our case 2 is a 30-year-old mother of one daughter, aged 6 years, who lived in Colombo. She came to us because she had end-stage kidney disease due to IgA nephropathy, awaiting commencement of hemodialysis, looking for a live kidney donor. She had recurrent episodes of volume overload and therefore needed hospitalization for hemodialysis. So we put a perm cath to try and expedite that, but unfortunately it didn't work. So then she was on a list to get a to create an AV fistula, but the date for AV fistula creation became postponed repeatedly because of a very, very heavy operating theater list. So she was coming to a hospital repeatedly, waiting for the AV to be created and coming with pulmonary edema, and then we would dialyze her with a central line and send her back out. With regard to her social environment, her story is interesting. The parents died when she was very young and was brought up by her grandmother, who was a daily wage earner. When the grandmother also died, she married her husband and moved with him. Now she lives with her husband, daughter, brother-in-law, who is a drug addict, and mother-in-law. The house has 2 rooms, one for this family, one for the brother-in-law, and there's a living area where the mother-in-law lives. There's a shared toilet and a kitchen where the mother-in-law cooks, and there's difficulty to adhere to aseptic precautions as well as to dietary advice that we give regarding her kidney disease. The husband is in the informal sector. She's a motor mechanic. He repairs 3-wheelers, but he doesn't have a garage space, so he actually does the repairs on the pavement. He can't work on rainy days because then, you'll all get wet. And on the days that he works, he earns about 1,500 rupees per day. Now, when she's in hospital with pulmonary edema, her daughter can't go to school, so the daughter actually stays with the father. And this photograph shows the father and the daughter by her side. He's doing his work, and she's just keeping him company. So what about our patient's future? It's very unlikely she'll ever be able to afford a kidney donor because that costs about almost 500,000 rupees. In the state sector, when we do start dialyzing her, we'll be probably under-dialyzing her, so she'll have recurrent pulmonary edema anyway. And we have a quota for dialysis for people who don't have a kidney transplantation plan, and once that's over, that's the end of the road for her. And what about her daughter's future? So you can see failure and a dismal future written into her story already. What are the health issues of the Colombo's urban poor? There has been some sociological studies done here. In 1982, the Mark Institute published a fairly large study. Basically, the main thing that they found is that there's very good coverage of immunization, and therefore there are low rates of vaccine-preventable diseases. Also in the 1980s, Professor Kalinga Theodore Silva from Peradeniya and his PhD student Karunanayake Atukorala did a study, which they published a little while later, based on 4 communities, 2 from Colombo, 1 from Kennedy, and 1 from Negombo. They found, very interestingly, a high infant and child mortality rate, almost 10%, which is like amazing compared to our national rate. And they also had a very high abortion rate, which was not caught in the statistics, but when the mothers were having informal conversations, they mentioned that getting abortions was a very common practice. And also very high infection rates. Average out-of-pocket expenses on curative services was about 3.6%, even though they were using the state services as well. There was a heavy reliance on takeaway foods because there was no cooking space at home, or because it was less expensive or more convenient. Most relied on tap water, but almost never on boiled cool water, and the reason for that was certain cultural beliefs, as well as, of course, the expenses and the inconvenience. But these researchers didn't actually study specifically malnutrition, alcoholism, drug addiction, and sexually transmitted infections, which are all considered to be much more common in these groups than in the rest of the population. So these are some of the diseases that were recalled in the past 30 days. You can see that there are some very high rates of conditions like infections, skin diseases, worms, and so on. The next study that was done by a sociologist was in 2008 when Professor Ratnayaka, who's from the University of Sri Jayawardenepura, did a study, another large study of the Colombo North underserved populations. For him, one of the biggest problems was that the inhabitants thought that many of the illnesses you were asking about were considered to be part of normal life. So they thought, that's not a disease, that's how we live. So therefore, there's going to be underestimation as well. He found major aspects in their life which were important for healthcare, such as water pollution, poor sewage disposal, poor garbage disposal, inadequate water supply, and indoor air pollution, in spite of the fact that these people had very good access to state services, both the health sector services and the other services. He also found large numbers of conditions like phlegm and skin disease and cough and diarrhea in that population. So I have one more case to share with you. This was a 71-year-old woman living with her son in Obesekarapura. There was a past history of mitral stenosis and surgery and a fast AF, ischemic heart disease, asthma, all these things combined to produce severe breathlessness. She has already defaulted on her follow-up from cervical dysplasia stage 2, and she was on intermittent self-catheterization for urethral stenosis. And now she came to our ward with lung infection. Regarding her social environment, she lived in a wood plank house with 2 rooms, a hall and a kitchen with poor ventilation, and it was getting flooded each time it rained. Next to the house was a dirt-filled canal with a garbage pit and rodents and flies and mosquitoes. She herself was a former maid, but now unemployed because of her breathlessness. The son is a drug user and not interested in the work, and there's no regular income except the asvasuma, which gives them 7,000 rupees a month. He ate only 1 meal per day and can't cook because, there's no money and no space. So they just bought a meal from outside and they had only 1 meal per day. And of course, you can understand that there's also great difficulty finding transport to hospital. If you look at our own management plan for her, we have separate specialist clinics for her. General internal medicine, warfarin clinic, urology clinic, gynecology clinic, and the lab test clinics. Our medication advice is impossible for her to adhere to with regard to warfarin. Our warfarin in the hospital has varying bioavailability. That means INR checking is very important, but she can't do that. So she runs the risk of either getting thrombosis or bleeding. And of course, there's poor hygiene at home, so her self-catheterization is very dangerous. And she has severe breathlessness. She can't walk to the bus stop, nor travel in the bus. So she needs a 3-wheeler to travel both ways to hospital for several clinics every day, which of course, naturally, she can't do. So my take-home message for you, ladies and gentlemen, today is that the urban poor is a distinct group of people with distinct socio-demographic characteristics and healthcare issues. Their distinctiveness and needs are often not noted or accommodated by the healthcare system. The healthcare sector may need to consider modifications to its practices if this group of people are to be served effectively and adequately. As long as their lifestyle persists, due to the persistence of the social determinants of health, these distinct features too will persist. So the problem won't go away. So my last slide shows you some sad news, a postscript for our story. So I told you the story of that young mother who had a very young girl. The father is a 3-wheeler driver mechanic, and the girl stays with the father during those days when she is in hospital with pulmonary edema. A few days after our presentation, the medical student who was the group leader for that group sent me this very sad message about what has happened to them. So when I read that, I realized that some of their stories have come to an end, but the rest of the stories are continuing. Thank you for your patient listening.
Thanks, Panduka. So the 3 speakers have utilized the full time of the symposium, but we can have 2 questions from the audience.
Thank you, Somia, for an excellent talk, as always. You did a couple of analyses you presented, like from the middle-income countries and things. Did you take a variable of religion? Because, different religions have different perceptions as far as they are allowing a woman to work, number one, and number two, to be in the lead position, not to be follower, but a leader. And another thing, I think in a country like Pakistan, where we have huge fallout rate of around 75% female doctors, they don't even end up working. Probably it's something to do with women themselves also, and also the males dominating the scenario. You want to comment on these two?
Yeah, thank you very much for your comment. First of all, I did not study the religion as such as the challenge for women advancement and career, but the gender gap analysis of the World Economic Forum, the least 10 countries in the ranking, which are mostly they are Muslim countries. So Afghanistan is the lowest, then is the Pakistan, then there's Yemen, and the rest of the countries, few from Africa as well. The top countries are all European countries. Iceland is at the top, then Finland, Netherlands. The European countries are doing well. So we've not analyzed religion as an enabler or a challenge, but this is a possibility that because of religious belief, people do not want to work. Secondly, about the dropout rate for women that they don't want to work, we need to question what is wrong that they don't want to work. They don't want to work because the system is not friendly to them. They do not have the opportunities of a daycare facility. They do not have the opportunities of flexible working hours or long maternity leaves. So I think, again, if somebody is dropping after studying for so many years of medicine, I think the blame has to go to the system which does not enable or help that woman adapt to the environment. Motivation and persistence is something which is required at an individual level, but the change has to be brought into system to know why there is such a large dropout rate in the female population.
Thank you, Dr. Somia. I will take the question, gentleman. Yes, sir.
Thank you. I'm very aware that if you've only got time for 2 questions, you probably don't want 2 questions from gentlemen. So I'm going to hand it over in case anyone else would like to ask a question.
No, sir. Please
Are you
go
sure?
ahead.
Okay. Well, I'll keep it quick. Actually, I've got a quick question for Emma and then also for Somia. Firstly, for Emma, my limited experience is you talked about these doctors, once they get into the system, having been refugees as being assets. And my experience is that they're not just assets, but they actually work over and above, because they're grateful or so glad to be working again. So I wondered if you'd experienced the same, if you find that actually they're great contributors to the system once they're able to work.
Yes, very much so. I think the sheer delight at being able to start working after so much effort, time, preparation, sacrifice, personal sacrifice, has happened to be able to get into a place of work. Yeah, there's a huge sense of gratitude in those initial periods. And I think the sense that I've got from the doctors that I've worked alongside, just really keen to have some period of stability when their life has been turned upside down and every aspect of that has been shattered in some way. So having that stability of work and regaining that professional identity and doing what they've been trained to do, skilled to do, and to share that and to contribute that back into a clinical team, yeah, makes them a great asset.
Is there time for a quick question for Somia? Yeah. It was great to see the programs that you've set up in Pakistan and to hear about all the other global women in leadership programs. I just wondered, do you, in your program in Pakistan or maybe in the other programs, do people collect evidence of the impact of the program in terms of how it's improving the rather distressing numbers that you showed us to begin with in terms of percentages of women getting involved in leadership roles?
Yeah, so it's a very short period to have that impact actually in the change, but we've got a feedback from the participants which is very, very encouraging because they think now that they are in a better position for their salary negotiation, for their job interviews. It has given them a confidence to become leaders, and also many other organizations have started their women leadership programs in their institutions, seeing this program coming from Pakistan Society of Internal Medicine. So they were able to, some of the participants were policy makers as well, senior female leaders in the champions group, and they were able to have few points included in the policy making, in the framework of the healthcare system as well, where they could have a facility of a daycare at every institution, the breastfeeding places, the long maternity leave, paternity leave approved. So there are small changes that are making their way, but I think it's only been a year since that program, and it needs a repetition and a refresher course so that we have a larger cohort, and more the merrier. The more the people will join in, more women physicians will come into power, and when women leaders are there on the deciding table, I think they will take good decisions. Thank you.
Ladies and gentlemen, with this we come to the end of the this interesting symposium. May I now invite Professor Diniti Fernando to hand over the tokens of appreciation and the certificates to the speakers. May I first call upon Dr. Somia Iqtadar.
Thank you very much, guys. I kindly request all our guests remain in the hall as we have a picture quiz happening after this before the tea break. Ladies and gentlemen, please remain seated. Thank you.